Today we will see some of the menstrual abnormalities, the main one amenorrhea and dysfunctional uterine bleeding. Amenorrhea means absence of menstruation. Hypomenorrhoea means reduced menstrual bleeding, but the menstrual cycle is of normal duration and it is regular. Oligomenorrhea means increase in the duration of menstrual cycle, that means more than 35 days. Hypooligomenorrhea, reduced menstrual bleeding with increased duration of menstrual cycle. Menorrhagia, the amount of menstrual bleeding is increased but the rhythm of menstrual cycle is maintained. Polymenorrhoea, otherwise known as epimenorrhoea, reduced duration of menstrual cycle. That means the cycle is shortened to less than 24 days. Polymenorrhagia or epimenorrhagia, amount of bleeding is increased and the menstrual cycle is reduced to less than 24 days and the menstrual loss is heavy and may last longer than 8 days. Metrotaxis or metrorrhagia. It is a acyclical menstruation. Menstrual cycle may be irregular or the bleeding may be continuous but the amount of loss may be normal or heavy. Amenorrhea. As we have seen earlier, it is the absence of menstruation. That means one or more missed menstrual periods. Women have missed at least 3 menstrual periods in a row have amenorrhea, as do girls do not have begun menstruation by the age 15. The most common cause of amenorrhea is pregnancy. The types: false amenorrhea or kleptomenorrhea, or true amenorrhea. True amenorrhea may be physiological or pathological. Pathological can again divide into primary and secondary. False amenorrhea. This happens due to a congenital anomaly. The endometrium is shed regularly, but due to the physical obstruction in the lower part of the genital tract, the menstrual blood does not escape out of vaginal introitus. It is a concealed menstruation. As there is no external bleeding, so the diagnosis is made. The causes may be imperforate hymen, vaginal septum, non-canalization or absence of vagina, blockage of cervix or atresia. This may be congenital. It is due to failure of canalization of lower part of Mullerian ducts. Acquired, it may be due to infection, trauma, cauterization or irradiation or operations. After menarche, in case of obstruction in the lower part of vagina, the menstrual blood continues to accumulate in the upper part of the vagina. This part of vagina is stretched and accumulation of blood forms a mass which occupies the pelvis. It is called as hematocorpse. The blood remains in a fluid state but water content is absorbed, so it becomes thick, dark and chocolate colored. In case of an atresia of the cervix, the blood accumulates in the uterine cavity. It is called haematometra. The presence of blood for a long period of time may initiate chronic inflammatory reaction in that part of the vagina or uterus and fallopian tubes. If infected, it may result in pylocorps. Clinical features include failure of onset of menstruation, pain. The patient gets cyclical, periodical attack of lower abdomen pain. This is due to discharge of blood and stretching of the vagina and uterine wall. Acute retention of urine. The mass of hematocorpse may press the internal urethral meatus and cause retention of urine. The signs include secondary sexual characteristics. They are well developed. Dark bluish membrane. It may be visible at the introitus. This may be seen in imperforate hymen mass. A uterus is pushed upwards. A large mass is usually visible in the lower part of the abdomen. Cytohormonal studies can be carried on the urinary sediment because bladder mucosa responds to estrogen. Investigation USG, it identifies the large fluid collection in the area of vagina, uterus or fallopian tubes. Treatment include cruciform incision, the incision of the obstruction of the membrane and excision of the large edges to relieve the obstruction in the lower part of the vagina by an imperforated hymen vaginal septum. The chocolate colored fluid is allowed to drain slowly over next few days. Vaginoplasty, construction of a new vagina. In case of haematometra, due to absence of vagina, a new artificial vagina may be created. Dilatation of cervix. In case of stenosis or atresia of the cervical canal, dilatation may be succeeded. Prophylactic antibiotics to avoid introduction of any sepsis. True amenorrhea. As we have seen earlier, true amenorrhea can be either physiological or pathological. Pathological again divided into primary and secondary. Physiological amenorrhea, that is in that case before menarche. Usual age of menarche is between 11 to 12 years. The menarche may be delayed up to 18 years. This amenorrhea is due to low production of gonadotrophic hormones from the anterior pituitary. Adolescence. After the onset of menses, some of the cycles are irregular. During the phase, there may be a period of amenorrhea lasting for few months. Pregnancy, lactation, and menopause. These are the 5 situations in which we can see physiological anemia. Second one is pathological amenorrhea. Primary amenorrhea, if this woman does not menstruate although she passed the age of 16 years. Secondary amenorrhea, the menstruation stops for at least 6 months after the woman has menstruated regularly or at least once. This is 10 times more common than primary amenorrhea. Causes of secondary amenorrhea. In most cases, nearly 95% of the causes lies in the axis of hypothalamus, anterior pituitary, ovary, uterus, and other causes. First one, hypothalamus. Any disturbance in the hypothalamic region of the brain may disturb the function of anterior pituitary and cause amenorrhea. The following are the common disturbances of hypothalamus cause amenorrhea: psychological, neurological, iatrogenic. First one, psychological. Hypothalamus controls the function of pituitary by sending messages through GnRH hormone. When hypothalamus is disturbed, the GnRH are not released, hence pituitary function is disturbed, and which causes amenorrhea. Common psychological conditions which cause amenorrhea are stress, excitement, depression, approaching examination and marriage, change of environment, climate, surroundings, and job. Anorexia nervosa, bulimic nervosa, strenuous exercise, pseudocyesis. Women who have a great desire to be pregnant or not to be pregnant may develop all symptoms of pregnancy, including amenorrhea, without being pregnant. Second one was neurological causes. Organic lesions of midbrain may cause amenorrhea. The common lesions are absence of neurons producing GnRH, that's Kallmann syndrome, anorexia nervosa, McEwen-Albert syndrome, inflammatory like encephalitis and meningitis, traumatic like fracture of the base of the skull and subarachnoid hemorrhage, neoplasms like infiltrating disease of the hypothalamus, drugs like phenothiazines, digoxin, lajactin. Anterior pituitary. Anterior pituitary produce gonadotropins which act on the ovary and stimulate primordial follicles to form graphene follicle and corpus luteum. In the absence of gonadotropins, the ovaries do not produce estrogen and progesterone, resulting in amenorrhea. The following are the defects of anterior pituitary which cause stoppage of gonadotrophin productions, that include first in ischemic damage due to the spasm of blood vessels of the anterior pituitary which causes local thrombosis, which occurs in PPH and leads to Sheehan syndrome. Neoplasms of anterior pituitary, usually adenomas, cause acromegaly, Cushing syndrome. Hypophysiectomy, surgical removal of anterior pituitary for the treatment of neoplasm of pituitary causes amenorrhea due to absence of gonadotrophin. Third one was ovaries. Any of the following defects in the ovary cause amenorrhea, like absent ovaries, abnormal production of hormone, neoplasms, premature ovarian failure. First was absent ovary, chromosomal anomalies like Monosomy or Turner syndrome, surgical removal of ovary, irradiation for treatment of caseous cervix. B. Abnormal production of hormones like failure of ovulation, PCOD, neoplasms of the ovaries, the premature ovarian failure, loss of ovarian follicles and their functions before the age of 40. This happens 1% of population. Common causes hypothyroidism and autoimmune diseases. Then fourth one is uterus. Absence of uterus. Congenital absence of uterus is due to defect in development of the Mullerian ducts. It causes primary amenorrhea. Other causes include endocrine disease like hyperfunction of thyroid gland, hyperfunction of adrenal cortex and diabetes mellitus, acute and chronic illness and stresses. Management of amenorrhea. First, we have to get a detailed history about the patient, general physical examination, pelvic examination, investigations, and treatment. History: age of menarche, of sister and mother, any history of injury of chronic ill health during infancy or childhood, history of emotional absence of change in the environment, history of drug intake, tranquilizers, hypotensive drugs, history of postpartum hemorrhage or shock, history of acute infections like TB, history of suggestive of endocrine diseases, recent change in weight. General physical examination include personality of the patient, stature and weight of the patient, any stigma of endocrine disease, the secondary sexual characteristic, visual field examination, retinoscopy. Investigations include blood investigation include ESR, total count, differential count, peripheral smear and RBS, urine for glucose, protein, pulses and gas, USG, abdomen. Radiological include X-ray of the skull for a lateral view, X-ray of the chest, intravenous urography for congenital anomaly of urinary tract or adrenals, hysterosalpingiography, it outlines uterine cavity and fallopian tube, CT scan or MRI. Hormonal assays like follicular stimulating hormone, LH, prolactin, testosterone, sex hormone binding globin, thyroid test, endocrinal biopsy, karyotyping to know the exact pattern of hormone abnormality. Laparotomy or laparoscopy. The treatment includes general measures like reassurance and psychotherapy, improvement in the general health and nutrition, treatment of the cause like then induction of ovulation. Second topic is DUB or dysfunctional uterine bleeding. DUB is defined as abnormal uterine bleeding without any clinically detectable organic pelvic pathology, tumor, inflammation or pregnancy. It is usually with hormonal disturbance and due to hypothalamic, pituitary, ovarian axis or HPO dysregulation. This in detail we can see in another presentation. Thank you for listening. If you have any comments, please let me know.